Today I will be assessing my patient, Katie Lewis's cardiovascular system. We will start with a detailed health history. Do you have any pain or discomfort in your chest?
No.
Do you ever have palpitations, such as an unpleasant awareness of your heartbeat?
No.
Do you ever have difficulty breathing?
No.
Good. Do you ever have a cough?
Not typically.
Not typically. When's the last time you had a cough?
I have a sinus infection right now, so.
Describe your cough to me.
Productive.
And productive as in there's mucus, so what color mucus?
Yellow.
Okay. Does it occur at any particular time of the day or just throughout the day because of the sinus infection?
Throughout the day because of the sinus infection.
Okay. Have you recently had any swelling anywhere on your body?
No.
That's good. Do you get up more than once during the night to urinate?
No.
Do you feel more tired than previously?
No.
Are you able to perform your usual activities without resting?
Yes.
Have you ever noticed your face, your lips, your fingers become blue or pale?
My fingers get blue and white, but I have Raynaud's, so that's the only time it occurs.
So describe to me what kind of temperatures it will occur in. Just when it's really cold, or is it?
Typically in stressful situations.
Okay.
Or when it's cold.
Okay, and how do you fix that?
I kind of just warm them up.
Okay. Do you have a history of heart problems or of heart disease?
No.
Do you have a history of a heart murmur?
No.
Congenital heart disease?
No.
Strep throat?
Yes.
Do you still have your tonsils?
No, I do not.
Okay. When did you get those removed?
My freshman year of high school.
Okay. High blood pressure?
No.
Elevated cholesterol or triglycerides?
No.
Peripheral artery disease?
Raynaud's?
Yep. Cerebral arterial disease?
No.
Diabetes?
No.
When was your last EKG?
Sophomore year of high school.
And why did you have the EKG done?
I think it was just part of a regular workup.
Okay. No abnormalities?
Nope.
And you haven't had one since?
Nope.
Cholesterol taken? When was the last time your cholesterol was taken?
Last year.
Okay. Have you ever had any other heart tests done?
No.
Is there any family history of coronary artery disease, hypertension, sudden death at younger than 60 years of age?
I think on my dad's side, my grandmother had coronary artery disease.
Okay. Any other family history of stroke, diabetes, obesity?
My grandmother on my mother's side had a stroke.
Okay.
And my grandfather on my mother's side.
Diabetes?
My dad.
Okay. So we will now move on to the physical examination part of the exam. We're going to start by taking vital signs and assess for pain. So we're first going to take your blood pressure. Take that. We're going to take your temperature. We're going to take your pulse. We're going to assess your heart rate. Okay, so we're going to wait for all of those to come back. So your blood pressure is 120/80. Your temperature is 98 Fahrenheit. Your heart rate is 60. Your respirations are 14, which I took as we were waiting. And you have a 96 oxygenation level. What is your pain on a scale of 0 to 10?
A 0.
Perfect. Okay, as we move on to the physical exam, I'm going to warn the patient that I will be touching her chest in the area to assess a lot of the cardiovascular symptoms. I'm going to need you to lay down for me. Is that okay?
Yes.
And as we move on to this exam, I will be touching your chest and I will be feeling around, palpating, and listening. Okay? So if you would just lay your head right over here for me. Okay. So this is me a 30-degree angle. If she was makes. So first I'm going to inspect your face. I'm going to expect to see if there's any swelling. So I'm going to examine my patient for any signs of edema on her face, any cyanosis or anxiety. I've looked at my patient. I don't see any signs of cyanosis, no edema, and no anxiety present. I have my patient laying down. She's elevated 30 degrees, which is what we're going to need for this exam. I'm going to get her just to look at me, and I'm going to feel her carotid artery. So I'm going to go thyroid, and I'm going to go slightly to one side. So I'm going on her left. going to use my middle finger and my pointer finger. And I'm going to check the amplitude of this pulse for 60 seconds. This should correlate with her pulse pressure. Okay. It does correlate with her pulse pressure, so it is normal. The amplitude of the pulse is brisk, and it follows the S1 immediately. I did not feel any thrills during this palpitation. I would listen for any bruits if my patient was middle-aged, elderly, or had cerebral vascular disease. The carotid arteries reflect apical pulse or aortic pulsations more accurately. If the patient had carotid obstruction, kinking, or thrills, they would be unsuitable to use the carotid pulse. If this was the case with my client, I would assess the brachial artery, but since she doesn't have any of these problems, I am going to continue on and skip that portion of the exam. The jugular venous pressure is best assessed from the undulations in the right internal jugular vein. So we're gonna still have the head bed elevated 30 degrees, and since we were already elevated, we're gonna keep it. Ask my patient to turn her head as she's already doing, and I'm going to assess her carotid or her venous jugular vein. And so we're gonna find the JVP, and to do that, this is gonna be a ruler, and this is gonna be just something that we're gonna help measure to do the test with. So I would examine, make sure I can see the external jugular vein, and then I could palpate for the internal jugular vein. Do that, make sure I can feel it. And I feel it right here. Put this right here, stick it straight out like this, and this is my ruler. This should measure no more than no greater than 3 centimeters. My patient's is normal. It is not 3 centimeters, it's no greater than 3, so she has a normal JVP. Next, I'm going to inspect the apical pulse, or the point of maximal impulse. First, I'm going to look at her chest, make sure it's symmetric, it's rising evenly. And next, I'm going to just assess for her apical pulse. So I'm going to start right here. She's still supine. Collarbone. Collarbone will put down. Sorry, I'm going to have to press a little hard on your chest, okay? Sorry about that. Okay. I'm going to go down to nipple line, so right about here. Okay. I'm assessing the location, the diameter, the amplitude, and duration of the apical pulse. So my patient had a normal apical pulse. There was no thrills, there's no heaves, nothing noted. Everything was normal. And I would do that for 60 seconds to get a fair assessment. When I did it and I palpated, I'm going to palpate the diameter. The diameter should be no greater than 2.5 centimeters. You can feel that by once you feel the apical pulse, and you can feel around to where you can still like palpate it. So then I would measure that. And that would be 2 centimeters, which is within the 2.5 centimeter range, which means my client is normal. Next, I'm going to ask my patient to roll onto her left side in the left lateral decubitus position. I've already palpated the diameter, which is 2, which is a normal finding, and I'm going to listen to my patient's apical pulse. Okay, I'm going to have to find it again, okay? I'm going to lift up your gauze strap a little bit so I can get a better hearing. Listen for 60 seconds. Okay. It was brisk and tapping, which is common. That is a good finding. It's a normal finding. Next, I'm going to listen to the apex of her heart, and I'm going to watch the stethoscope to assess the duration of the apical pulse. My patient's apical duration is supposed to last no longer than 2/3, and it should follow S1 and not continue to the second heartbeat. Okay, you ready? So I'm gonna listen to your apical pulse right here, and then we'll watch my stethoscope for 60 seconds. Okay? My patient had a normal finding. It lasted the first 2/3 of systole, and it did not continue to the second heart sounds. Next, I will assess the left sternal border in the 3rd, 4th, and 5th intercostal spaces. I will ask my patient to breathe out and briefly stop breathing to help improve my observation. I will assess the location, amplitude, and duration, and no increased AP. So I'm going to check for AP diameters. So, using my right hand, I'm just going to go right here, okay? Second intercostal space is right here. 3rd intercostal space would be right here. And 5th intercostal space will be right about here. Sorry. There we go. Okay. Do that for 60 seconds. Just to check. No increased AP diameter was felt, which is a normal finding. I will then palpate the 2nd intercostal space. I will instruct my patient to hold expiration while I look and feel for an impulse and feel for possible heart sounds. I'm going to go to your 2nd intercostal space. Right here. Okay. So I do feel an impulse. And I do feel for heart sounds. And since the apical pulse is palpable in my patient, there is no need for percussion in this instance. Next, I'm going to auscultate my patient for heart sounds and murmurs. I'll start at the base and inch my stethoscope to the apex of the patient's heart, which means I'm going to go from the 2nd intercostal space and move along to the left intercostal space. So start here, right 2nd intercostal, left 2nd intercostal, and I'm going to move along from the 2nd to the 5th. 3, 4, and 5, then the apex last. Okay, so I felt all of those areas. Now I'm going to take a listen, okay?
Okay.
Line is in the way right here, but this is 5. Thank you. Next, I'm going to keep my middle fingers on the right carotid artery in the lower 3rd of the neck so we can facilitate correct identification of S1 before the carotid upstroke of S2. So, we're going to take a listen. Apex of your heart, and I'm going to listen to and I'm going to feel for your carotid artery, okay? Here. S2 was louder than S1 at the base, and it was split when she breathed in with respirations, and S1 was louder than S2 at the apex of the heart. Next, I'm going to identify systole in the interval between S1 and S2, the diastole in the interval between S2 and S1. And as I did that as I listened to her heartbeat at the apex of her heart. Everything was normal, and it came out as 120/80. We've already had the patient roll into left lateral decubitus, and we listened with the diaphragm. The apical pulse was normal. There was no abnormalities. Next, I'm going to ask the patient to sit up. Do you mind if you sit up? Okay. So, lean over for me. Thank you. I'm gonna have you lean forward, exhale completely, and stop breathing in. And I'm gonna listen to your left sternal border and the apex of your heart, okay?
Okay.
Okay. So, tell me. Okay. Good, and good. Perfect. As I articulated the heart sounds, I would make sure to note the S1, the S2, the split S2, any extra sounds I heard during systole, extra sounds in diastole, and the systolic and diastolic murmurs. So no abnormalities were noted when I auscultated. Finally, I will assess my patient for peripheral edema. I will check her feet, ankles, and legs for edema. Do you mind if I take this real quick? I'm going to check your feet, ankles, and legs for edema.
Okay.
I don't see any when I inspected, so now I'm palpating to make sure that there's no edema present. Okay. No edema was present. And that will conclude the physical portion of this exam. Before you go, I would like to give you some health reduction and health promotion activities.
Okay.
To avoid the cardiovascular diseases, stroke, hypertension, health promotion activities you can involve yourself in to reduce the likelihood of having these diseases includes having a diet rich in fruits, vegetables, and low-fat dairy products with reduced contents of saturated and total fat. You can participate in regular aerobic exercise, such as brisk walking for at least 30 minutes per day on most days of the week. Avoid smoking and secondhand smoke. Consume 1 alcoholic drink or fewer per day. Maintain an optimal weight or BMI based on your age and height. And have a salt intake less than 6 grams or a sodium chloride intake of less than 2,300 of sodium per day. And that concludes our exam. Thank you for coming.
Thank you.